CT lung cancer screening, is it or is it not appropriate? I think as we explore this question, we first have to look at our history and the background behind lung cancer. To best do that, I find that it's best to look at our statistics. So we know from our cancer statistics that lung cancer continues in men and women to be the second most common cause of cancer. And that is predicted to be the case in 2015. And yet, it continues to be the leading cause of cancer death in both men and women. Now, what does that mean for us in the state of Texas? If you look at our demographics across the United States, we see that in both men and women, the incidence of lung cancer will continue to fall midway in the range when you look at the rates of development in men and women per 100,000 population. So this means that for Texas, we need to have these discussions with our patients because this is really something that's going to live in our backyard. Now, what do all these numbers mean? Well, in 2015, a true number that you can hang on to is that we will see over 100,000 cases of new lung cancer in the state of Texas. And we all know that we are a big tobacco state, so this is not surprising. We are only surpassed by the state of California in that incidence rate. We also know from our cancer statistics that if we localize, if we determine that patients have lung cancer at a localized state, their chance of 5-year survival is going to be greater than 54%. And the more distant disease they have, it's going to be significantly lower at the rate of about 4% for a 5-year survival. So without a doubt, we know we want to discover lung cancers and diagnose them at an early state. So the goal with lung cancer screening by low-dose CT, let's look at what the news is telling us now. In 2015, our scientists from Hopkins discovered or statistically proved that 2/3 of our cancers are due to gene mutations, random gene mutations. So that means we can't do anything to prevent you from getting the lung cancer in 2/3 of the case. But in lung cancer, we know that we have an environmental factor, a trigger, if you will, that places you at higher risk for development of cancer, and that's smoking. So we know that those patients need to be identified early. As I said, the 5-year survival is going to be greater than 54%. So to quote Dr. Tomassetti from Johns Hopkins, we should focus more resources on finding ways to detect such cancers at early curable stages. So the answer to whether or not lung cancer screening by CT is appropriate, well, we know for one point it's certainly needed. Now, until the NLST, which I'm going to elaborate on, came about, we really had no way of screening for lung cancer. We had a way of screening for colon cancer with colonoscopies, cervical cancer with pap smears, and we've been seeing the cancer rates decrease across the board. But for lung cancer, nothing was available. That was until the skies parted and brought us the NLST. So the National Lung Cancer Screening Trial came about in 2011, or at least the results did. It was a multi-center trial that involved over 53,000 participants. What they did was they took low-dose lung cancer screening and compared it to detection rates in chest x-rays. We performed over 26,000 low-dose CTs. And what was the result? Well, the result was astonishing. We had a 20% drop in mortality in those patients who were detected early. That's the first time we have had a major impact in the fight against lung cancer, which again, as I remind you, is the leading cause of cancer death in the United States. Now, it wasn't without its downside. In those patients we screened, of course, we had some false positive rates. Those false positives ended up resulting in patients who were a little more anxious about the findings that we found, but ultimately, of course, they were relieved to find that they did not have lung cancer. Now, the other fear with any screening exam is, are we going to cause an indirect increase in healthcare cost? So in that 56,000 participants of the study, what were our results? We only found 7.5% of incidental findings, and of those, they were not significant. So we did not result in a significant increase in the uptick or cost of health care. So for the first time, we had a good screening tool that didn't result in increased cost to health care. So this was a key turning point in the battle against lung cancer. So at UT Southwestern, as soon as we saw those results from a multi-center randomized clinical trial, we decided we should start our lung cancer screening program. And I want to distinguish a program as opposed to simply offering a low-dose screening CT. There's a big difference. A program is comprised of directorship, is comprised of a team of people, of clinicians, healthcare providers. In our program, we've got thoracic surgeons, thoracic oncologists, nurse coordinators, and of course our very important CT techs, because they keep that dose as low as reasonably allowed, which is very important in a screening program that's going to involve irradiation by CT. And last but not least, a key component of the program is a smoking cessation program. After all, we don't want to just screen patients and discover their disease, but we want to tell them that now that you know you don't have lung cancer at this point, let's change our behaviors. Let's prevent it from occurring. This is what got you into the high-risk category. How can we help you stay out of that category? So our program includes a lung smoking cessation program. Now, how do you go about scheduling a patient? There are two doors of entry into our program. One is through the PCP. A PCP can meet with the patient, discuss their risk factors, and then schedule. Our schedulers are aware of the criteria that make you eligible for scheduling for low-dose screening CTs. Patients can also self-refer, just as they do with mammography. We have our own physicians on the ground or licensed practitioners who can see that patient and discuss their risk factors, determine their eligibility, and get them into the program. What are those criteria? This I want you to pay close attention to. Age 55. If you remember nothing else from this talk, remember age 55 is where you start. You have to be 55 years of age in order to be eligible. You also have to have a 30-pack year history of smoking, and you have to have no other history of a cancer. If you stop smoking at some point in your life, then we want that to have been within the past 15 years. And that keeps you in the eligible criteria. And this is important because, of course, screening is not a single event. It's a marathon. This is something we want you to do over and over again every year until you go from the high-risk category to the normalized risk. And that takes 15 years to reverse that process. So who should screen? There are other thoughts about the screening criteria by other organizations, including the American Cancer Society, the American College of Chest Physicians, but all in all, they all start at what age? 55, yes. I've succeeded. Now, across the spectrum, you know that there are many, many, many CT scans. How do we perform the exam? If you noticed in our animation, that scan is still going. So at most, you can tell your patients that your scan, your time on the table, is going to take somewhere up to 20 seconds, depending on the type of scanner that we have. Even though there are different scanners, there's a requirement that the dose remain low. And the dose is going to be somewhere around the range of 1.5 millisieverts. And what does that mean to your patient? That's the equivalent of about 5 to 10 chest x-rays. And as you and I both know, for any admission to a hospital or throughout your lifetime, one can easily get 5 to 10 chest x-rays. And that dose to a 55-year-old patient is nominal. That means that we are not going to cause another cancer by screening these patients in this age population. Results management. What do we do once we scan the patient, once we get the results back? Once we talk to them about smoking cessation? Well, the next step is going to be to give the patient their results. So this is very similar to how we conduct a mammography program. We send a letter out to the patient if it's negative. and that results in our happy patient. We also send those results to their primary care physician. Even if they self-referred, the primary care physician is going to receive that message that the study was negative. Now, in the positive results, we do something different. We don't just send a letter out because, again, we're a program. We make a personal phone call to every positive patient that we have. And we have our commitment in our program to schedule that patient to be seen back in our screening clinic with a pulmonologist for a discussion, a consult, within 2 business days. So 24 to 48 hours, that positive result has an appointment back with us. And that's whether they entered in through self-referral or ordered by a primary care physician. Now, if the patient chooses to follow up with their PCP, they always have that option. As with always, we're going to give the result to the PCP, so they'll have that result to discuss with their patient. If we have any difficulty in reaching the patient, we send out a certified letter to ensure that we have made contact. And we gather all that data up front when the patient schedules. Now, how do we as the radiologist manage the finding of a positive low-dose screening CT? That means the patient probably has a pulmonary nodule. That nodule can be solid or it can be ground glass, as we refer to it. The key number here and the rule of thumb is 8 millimeters. If the lesion is 8 millimeters or greater, we do additional testing in the form of a PET CT or sometimes an invasive biopsy. If it's less than 8 millimeters, then that patient is more than likely going to have some recommendation for interval repeat scanning. And that's going to be in the form of a repeat scan every 3 months or every 6 months, depending, again, as you can see on this diagram, whether the size is less than 6 millimeters or between 6 and 8 millimeters. So that's the part where the radiologist comes in. We will make those recommendations. And this recommendation is based off of long-studied criteria based on outcome analysis. So in summary, the report comes out negative. We have happy patient. We send that patient and the physician their report. A positive result, we follow the ACR recommendations or the National Cancer Network recommendations for follow-up evaluation of 8 millimeter lesions or less, or 8 millimeter lesions or greater, based on long-standing research data. And those patients that are positive will be scheduled without any extra effort by us in clinic in 24 to 48 hours. What's the cost? That's the next step. Currently, for self-referred patients, these costs are based on national Medicare rates. So in the southwest region of the United States, we tend to be a little bit higher. So our rate is $299 as opposed to the national average of $230. Now that's our self-pay rate. No insurance. Come in off the street if you are interested in being screened and you meet the criteria. So you might ask yourself, why isn't Medicare reimbursing for this exam yet? Why isn't Blue Cross Blue Shield or Aetna? Well, let's look again at the history behind this. 2011 was when the results came out from the National Lung Cancer Screening Trial. Again, it was the first time we showed positive outcomes of a 20% drop in mortality. In 2013, the United States Services Preventive Task Force took a look at those results. They thought about it for a while. They came out with a memorandum, but 6 months later in December, they came out with their recommendation. They placed it into a Category B classification. Anything that goes into a Category B classification by the United States Services Preventive Task Force means that Medicare must reimburse. So that was in December 2013. Now, Medicare took their time. We know how long it takes to write a law or a bill or get it right. So it was just last week, I kid you not, last week after my slides were prepared, that they came out with their ruling and decided that they would finally reimburse for low-dose screening CTs. Now, they didn't do this without some criteria. Now, I say this happened last week for Medicare, but Obamacare, with the Affordable Care Act, said January 1, it's reimbursable. So any patient on Obamacare is reimbursable for a low-dose screening CT if they meet criteria. Medicare, has a couple of additional hurdles that you need to jump through. Okay, so they have requirements on the order. For a patient to be reimbursable, they have to first visit with a licensed independent practitioner. And in that visit, you have to discuss their risk factors. What are the risk factors for radiation dose? And they are nominal, again, the equivalent of 5 to 10 chest x-rays. And they have to meet the criteria. And what's that age again? 55. 55, that's right. So if they meet those criteria, then you can write the order and that will be a reimbursed exam. Now, after that first exam, again, screening is a marathon. It's something you're going to need to repeat if you have a negative exam. They can get that order on their annual physical. There's nothing important about that visit. You can rewrite for the orders for their subsequent screening exams. In the United States right now, Blue Cross Blue Shield now reimburses in the state of Texas as of last week. Aetna reimburses across the 50 United States. Cigna also reimburses across the 50 United States. So what's our goal with screening? We should focus more on resources in finding ways to screen cancers at a curable stage. So back to our title slide. Is CT lung cancer screening appropriate? Absolutely, in the right population. Thank you.